infection preventionists, nurses, physicians, emergency medical services, public health, and then laboratorians. We have something for all of those types of disciplines.
Wow.
And then anyone who's just interested in special pathogens, I think we're the place to come.
Hi, everybody. This is Chris with Readiness Rewired, a healthcare podcast. Normally, I pitch it to colleague Al to ask what time it is, but Al is taking this podcast off. So I'm actually going to kick it over to Mike, and Mike has a special guest for us. So, Mike?
Hey, glad everybody could join us. We've got a special gig here, everybody. It's time for us to address an issue which I think is becoming more and more pressing in our country, in our world. And it's something that we as a podcast group feel pretty strongly about, and that is our national posture to deal with special pathogens and bioemergency preparedness. We just feel that at this stage of the game, we in the world of healthcare emergency preparedness need to have as much knowledge as possible of what kind of infrastructure is out there for our country, how we can get a hold of it, how it serves us, and what it can do for the rank and file and the people right down on the boots on the ground at our nation's hospitals, healthcare clinics, wherever. And so we are very incredibly pleased and fortunate to have one of the people that I've had the privilege of having a good, decade-long relationship with over the past 10 years. This is Angie Vasa. She is a member of NETEC, and I'll have her talk about NETEC and what that acronym means and her position there. But I can assure you, this is one of the most knowledgeable, experienced, and practiced people in the world of special pathogens, right down to bedside care. And so, Angie, I'm going to kick it over to you to let you introduce yourself to our audience.
Great. Thank you. And good morning. Thank you so much for having me. So as Mike said, my name is Angie Vasa. I am a nurse by background. I've been practicing in nursing since 2008. And my background in clinical care was really focused in adult trauma, ICU, solid organ transplant, and then infectious disease. I joined the Nebraska Biocontainment Unit, which is here in Omaha, Nebraska, in 2009. And so I was fortunate enough to be a member of that team when we activated to care for individuals infected with Ebola virus disease from 2014 through 2015. And then had the pleasure of joining the NETEC consortium, which is the National Emerging Special Pathogens Training and Education Center. And I've been fulfilling a role in that organization as the activity director for consultative services, including metrics development, readiness assessments, and technical consultation for hospitals, EMS, and public health partners focused on high consequence infectious disease. And then I also have the distinct pleasure of serving at Nebraska Medicine as our health system director of emergency preparedness. And so my role now is split between clinical care responsibilities for the quarantine unit, which is our national quarantine unit, our biocontainment unit, and then managing a grant portfolio focused on emergency response and special pathogen preparedness.
Well, there you go. And so I tell you what, there aren't many people in this country with her background, her skill, and her experience and knowledge. And so we're really thrilled to have you. I got to know these wonderful people over at the University of Nebraska back in, I think it was January of 2015, right after 2014 passed, and we in our facility were engaged in trying to build a biocontainment inpatient capability. You know, we're an 860 bed academic medical center, but let's face it, back in those days when Ebola was the big threat, right, and remains to be a concern, not many places in the country would have the capability to safely care for something like that. And Nebraska was one of a very small handful that could do that. And that's what Angie was referring to, those 3 patients that they ended up taking care of. And she was one of the ones right there at the bedside taking care of them. And so who better to learn from? And so we made our first pilgrimage. I call it a pilgrimage, the 4-hour drive across Iowa to go over and spend a few days in Nebraska. And we first met you folks back then in January. And then we had learned a lot of things. We learned how unprepared we were for something like this, even though we thought we could get close. So over the last 10 years, we've interacted with them on a regular basis. I think I tried to get over there every single year, at least once. And then their team over there came over to us. I can remember when, and this was before NETEC was even developed. I think it was still in the planning stage. Your old medical director, Dr. Phil Smith, brought a 3-4 person team over to our facility to help us design our program and refine things within that first year or so, right before NETEC was actually official, if I recall correctly. And then you've been over a couple more times. And then, boy, we can get into this later if we want to, but then we had a case of Lassa fever walk in to eastern Iowa. And these folks jumped in a car, and a 3-person team, including Angie, came over to be at our side as we attempted to care for this patient. And I don't know what we would have done without him. So, I think the people who work in special pathogen care, whether it's at the bedside, the administrative side, the education side, the research side, really doesn't matter. These are some of the most spectacularly, phenomenally dedicated professionals who also have that personal empathy to want to help, So it's that unique combination of devotion professionally and, as Chris said, personally as well. So we're just so great to have you with us. Chris, you got a thought you want to throw at her?
Yeah, I kind of represent the front line, the critical access, the folks that maybe we're clearly in awe of the things that happen at the tertiary care facilities, the university hospitals, the teaching hospitals, and so on. But I think what's unique about NETEC is that you have the comprehensive portfolio of training and education. So it's really, plain language, state-of-the-art information on a number of different platforms. So it's a resource to really everybody. And you clearly work at that highest level. I think we'll want to hear a little bit more about who are the elements of NETEC. And as listeners continue to hear about and relate to some of the stories that'll be shared, they should rest assured that while the expertise is there for the highest level of engagement and complexity, but you're also building tools and putting stuff out there, engaging with people on the front lines with little or no experience in the clinics and the hospitals to try to, as the first line receivers, be prepared as well. And so I'm interested. I'm in for a real learning experience here, and I'll turn it back over to you two to download.
Fantastic. So I might start by just a little bit of an overview. Although NETEC has been established and been funded through the Administration for Strategic Preparedness and Response, or ASPR, since 2015, so this is our 10-year anniversary year, we really haven't had as much reach as we had anticipated that we would. So as with all types of different emergency response fields, you get into a niche area and you're very well known, well respected, well circulated within that community. But getting outside of that group where the priority is focused on infectious disease response is sometimes challenging. And so to level set around who are we, what is NETEC, and what do we do, to your points, Chris, is really, we're a consortium founded through 3 institutions. And we were selected because in 2014 and 15, each of our institutions cared for patients with Ebola virus disease without any staff or community transmission. And so Emory University Hospital in Atlanta, Georgia, New York City Health and Hospitals Bellevue in New York City, and then Nebraska Medicine, UNMC here in Omaha. And so there's a triad of leadership. And our team has really put together a network comprising 15 different hospitals, 13 regional treatment centers. So at least one hospital in each of the health and human service regions. And the four pillars of work that NETEC focuses on are one, first and foremost, training and education. And so we focus on development of resources and tools aimed at the frontline provider. So infection prevention, emergency department staff, clinic staff, and then all nursing and providers who would be providing care, either inpatient or in the emergency department setting. And then we have assessment and consultation. And that's really the arm that goes out and we partner with all facilities. When Mike was saying that a 4-person team came to Iowa before NETEC existed, those types of collaborative visits have formed the foundation from which we've developed our site assessment and consultation team structure. And so even now we'll send either virtually or on site a team of 2 to 5 people, depending upon the needs of the facility. It includes a physician, a nurse, a laboratory specialist, operations management, and then EMS. And so a combination of those types of individuals to partner with an organization and really get into the weeds on, do you have a plan to identify individuals who may be suspected to have a high consequence infectious disease? Let's look at your isolation plans, your physical infrastructure, your protocols, personnel management. We look at waste, cleaning and disinfection, all of those elements. They're actually now addressed by the Joint Commission, which we can get into in a little bit. But we look at all of those elements side by side. We're not a regulatory body. There's no punitive impact for our visits. It's really a collaborative measure to help people feel empowered to implement the changes that would be needed to make response safer. And then we have a Special Pathogens Research Network. And this is really a group that has been formed to stand up the infrastructure to have rapid response research in the face of an emergency response. In infectious disease response, you don't have a lot of time to go to the institutional review board, put together a research protocol because the patient's already in the unit. And so this group has worked across the network to develop standing protocols, a centralized IRB, so that should something happen, we can quickly implement a protocol. So we're not funded to do research, but we build the infrastructure across the country to get access to medical countermeasures, monoclonal antibodies, a biorepository, to all of those specimens that can advance the science of infectious disease response, have a place to be stored safely. And then lastly, our fourth area is international partnerships and programs. This has been in place for about 4 years and was really instrumental in the initial and ongoing response to COVID or SARS-CoV-2 in the beginning, to understand from our partners across, Southeast Asia, Europe, parts of Africa, what are other people seeing and how can we learn from each other and those early indicators of treatment and response options. And so those 4 pillars of NETEC are really where we serve the community across those different lanes of activities. I think the only other thing that I would add is to your question around what's available for critical access hospitals, what's available for people that aren't standing up biocontainment units. And this is really where we've shifted our focus, particularly over the last few years, is to better establish a tiered structure, very similar to the trauma system, very similar to stroke and burn. Not every facility can be ready for everything. And so how do we equip everyone from any point of entry to a healthcare system? And so we've modified all of our tools to be applicable. So whether you're holding somebody for 24 hours, you're testing and then sending on for higher level of care, or you're keeping somebody for the duration of illness, we have tools and personnel who can tailor the resources to meet your needs. So for critical access hospitals, we can connect you to your regional treatment center. So you're in region or in state local resource set of experts. We have protocol templates. We have training materials, both asynchronous and live. And so we have just a suite of options depending upon where you're at in the preparedness journey for high consequence infectious disease.
So let me ask then, the point of entry for a browser, a person that just wants information, is probably your website. But if you've got an incident starting up or something, a suspected case, is that a phone call? How does that sequence work?
So there's a variety of ways. So I think two things. One, on our website, we do have a contact us section, and that lists out all of the regional treatment centers. So, all emergencies are local, they start local. And so how do we get people to know, who do you contact? So if we have somebody that's in Region 7 and they have never met us at the Nebraska Biocontainment Unit, NETEC has a map that you can open, and it lists our points of contact, including our number that you can get a hold of somebody. If the regional treatment center doesn't have that 24/7 access line available on the website, or you don't know it, what we would advise is to go to the local health department, local or state, depending upon how your jurisdiction is structured. And then all of the ASPR regional emergency coordinators, or the RECs, also know how to get a hold of each of the regional treatment centers. We've all developed state and regional concepts of operations, or CONOPS. And so the probably easiest way to get a hold of us would be to go to the county or local health department, who would get a hold of your ASPR federal representative, who would then structure back through the CONOPS to activate that consultative line. All of the regional treatment centers are available for immediate consultation. And then alternatively, we also have a 24/7 NETEC line that our principal investigators man. So we do have access. People have access to us through the ASPR Secretary Operations Center or from CDC's Emergency Operations Center. So both of those federal agencies have the 24/7 number to call NETEC if you need a larger response structure.
Awesome.
Right, because I think the way it worked with our case, and just to throw it out there as sort of an example, you know, the patient that we had walked into an urgent care, like a doc-in-the-box clinic. That doc-in-the-box clinic thought there was something wrong with this. This didn't sound quite right, something a little bit more than what we should manage. And they actually called for EMS to have them transport to a nearby community hospital. Now, as I understand that sort of thing, the way the National Special Pathogens System of Care is designed, like you mentioned, was like trauma, like stroke. That would be the kind of the lowest entry level. That would be like a level 4 type of facility. Is that correct?
That's correct. Yes.
So the
We have
level
a level 4 where you would what our aim is that every point of entry into a healthcare system would be prepared to quickly identify somebody who either meets signs and symptomatology for a high consequence infectious disease that is coupled with a significant travel history where there is an ongoing outbreak of concern, or an endemic high consequence infectious disease that's always present, which may raise the index of suspicion for something outside of the norm. So fever, cough, rash, those could be anything. And so when you couple that with the travel history, that's where we really want anybody to be able to flag and say, we might not know what this is, but we know that there might be something more than what we routinely see, and then know who to call.
So the pillar of that from a clinical perspective, and I know NETEC has been pushing this and we're trying to get it, and I'm hoping, Joint Commission and others have adopted this same approach, is identify, isolate, inform, correct?
Yes, the 3 I's.
So
And that
that,
really, I'm sorry, Mike, I didn't mean to speak over you.
no, that's fine.
Get excited. The Joint Commission last July, they did release a new infection control chapter. So IC 070101 is the new special pathogens or high consequence infectious disease standard. And that really is where they have added in the identify, isolate, and inform. And so within their new standard, the elements of performance indicate that all healthcare systems who are accredited by Joint Commission, but we hope translates out through DNV accreditation and other, other types of accrediting bodies, is that you should be able to promptly identify somebody who is suspected to have an infection caused by a special pathogen, to be able to have the means to quickly isolate to prevent community and staff transmission, to know who to inform and when to inform those individuals to do a more thorough assessment. And then the other components that Joint Commission has included around cleaning and disinfection. So do you have plans to sequester waste? Do you have plans to safely dispose of any materials contaminated by an individual suspected to have a high consequence infectious disease? Is there a plan for treatment and care? And then the part that they put in that is aligned with the way that Joint Commission does a lot of their evaluations is that staff that would be expected to execute these protocols can have completed education and demonstrated competence. what's nice about Joint Commission is that that's really defined by the organization. So they haven't said you must do A, B, and C, but rather, what does your organization define as education, frequency, and how are you assessing competency? So it aligns with all of their other standards, but it's really the first time since 2015 that we've seen a regulatory body start to incorporate special pathogen preparedness into their standards. So that's a huge step forward for the national system.
Absolutely. And I think one of the things that our case demonstrated is when that system can work and what happens when it's not followed. We had over 170 people that were exposed to the case that we had in our part of the state. And we look back and say, okay, even though the case that we had, it was not a successful case from our perspective, from a care perspective, because it did not have the end result that we build these units for, right? But even with 170 people exposed, there were no other transmissions, which we were very fortunate in that case, because I think the 3 I's were not, I would say, religiously followed throughout the whole course of that case. And so that's one of the messages, one of the take homes, one of the after action reports that, list things we can do better and get the word out about the 3 I's and make sure that gets done. I don't think a special pathogen consideration was even in the mix until I think the patient hit our door. And it came to our door not as a special pathogen suspected case. It was just because of the ICU level deterioration of the patient, which it just so happened we also could do both. And it could be determined within 24 hours. We had that case identified. But boy, things that can be done better, we really need to emphasize.
Yeah, and I think one of the key components that you're alluding to is when there is an endemic pathogen like Lassa fever, it's always present in specific countries within, West Africa and across different countries in Africa. If there's not an outbreak of concern, it doesn't always raise the flag for people. And so when somebody comes in with tropical travel and we ask the standard questions, were you in contact with anyone who was ill? No. How long have you had the symptoms? 7 to 10 days. The malaria differential that was, followed up on. A lot of the things that we look at, we start to see negatives. If we don't have a definitive diagnosis, that's really where that escalation has to be hardwired in is, we've looked at the standard bacterial, we've looked at the standard virology, we've looked at the parasitology. Something is still happening, but we don't know what. And then who do you call quickly to make sure that you get that expert consultation? It's like in your advanced cardiac life support, always seek expert consultation as early as possible. And so that's, I think, one of the key pieces. I think the second is, my personal opinion is that throughout the response to COVID, we've become complacent as healthcare providers because we were told, for many years that we had to wear this highest level of PPE. And so I think we've seen a shift in the mentality of, well, we took care of COVID and we were fine. We can take care of anything else that comes in. And so there's been a shift in I think the level of fear and respect for high consequence infectious disease, where we used to have a lot more. I think now there's a little bit more apathy around how people feel, the level of concern that they feel that they should have, which is an interesting shift.
It's not a good shift.
It's not. No. Yeah.
So a couple points, I think. One is the Joint Commission that you mentioned is often kind of the bellwether regulatory body that later CMS adopts, and as you mentioned, DNV and all. So even local, or not local, but maybe state level departments of inspection and appeals will be looking at too. So it would serve people well, whether they're governed by the Joint Commission or not, take a look at those standards. And then as a practical point, do you have case studies or drills? Because I think a lot of our folks are sitting in maybe relatively rural, situations where they're seeing the seasonal coughs and sniffles, but how would they recognize and, process an unusual case and practice that so they can really start to hardwire their mindset and also recognize that they have that capability. They just need to practice it and standardize it.
So I think there's three things that come to top of mind for me. Is number one, we developed what we call the viral hemorrhagic fever, or VHF, preparedness checklist. And that really is a 6-section tool. It takes about 10 minutes to complete. They're all binary yes, no questions and answers. And it's a starting point for an organization to really look at and see, do I have these elements in place? And so it goes through identify, isolate, and inform, treatment and care, transport and testing, waste management. So it goes through those major categories of pieces of care that you would expect to encounter in the first 24 hours of identifying an individual. That's available on our website for either download. We'd prefer that you do the live survey version so we can aggregate the national results and then share that back to the regional treatment center.
Mhm.
But we also recognize that people are wary about providing information. So we do have it downloadable in a PDF that you can reiterate on. So that's the first one. The second thing that we have is what we call mystery patient drills. And so these are no notice exercises. They do follow the HC guidance. And so they're compliant with any exercise requirement that your organization may have. And it walks through a scenario and how could you go into either your urgent care, your emergency department. I can tell you a little anecdotal story about how we noticed our clinics, and that you should always have a trusted player somewhere in leadership if you're going to do one of these,
Yeah.
just as a lesson learned. But that's a really good way just to pop in, and it doesn't have to have, a large footprint. And so you
Right.
just walk in and say, if I was presenting right now and I told you these 5 things, what would your next step be? And so it can be as casual or as formal as you want it to be to get your organizational staff starting to think about those things. And then the third thing that I would say that we have is really we have an emergency management work group, which is comprised of individuals from all of the regional treatment centers. And so that is a group of, I think 15 to 18 individuals who all have special pathogen expertise as well as emergency management background. And they're available for consultation. So if you submit a request through info@netec.org, just saying, we're looking to design an exercise, a workshop, a tabletop, how do we get our organization started on some of these preparedness activities? We have a national work group that handles those types of requests and can partner with you or with your regional to start to figure out where are you at and how do we get you where you want to be.
Wow.
So now comes the big question, and I think probably one of the major sort of hurdles that we have to cross in the world of healthcare emergency preparedness. There's so many things on our lists as emergency preparedness people that we would want to put into a scenario, an exercise, a drill, or whatever. And you look at your hazard, your lists, your hazard vulnerability assessment or analysis that you do for your facilities. And unfortunately, it seems like something like this doesn't really fall at at the place in your list where you give it a lot of attention. I would guess that there's so many institutions across the country of all different sizes where something like this isn't making the top 5, maybe the top 10 even. And so I have something to tell you as one who maybe thought that way years ago. Our case that happened in the latter part of 2024 in rural Iowa, where a case of Lassa fever walked into an urgent care in a small town of no more than about 10 to 15,000 population, illustrates the point that it can happen to anybody. Okay, it can happen to anybody, and that's the take-home message. And one of the reasons we wanted to get Angie on here is because, look, it could happen to you. And you go to a major city somewhere, and you think, oh, we're the ones that will probably get something like that. Well, you may think so, but it can happen anywhere, and so it is worth the time to address this issue somewhere in your hazard vulnerability analysis, into your yearly planning, and then start using the assets and resources that NETEC's already done for you to help you do your job, and they make it a lot easier.
Yeah. And I think the mantra that we come back to is ready or not, patients will come. And with the nascency of the National Special Pathogen System, people are going to present for care where it is closest and where they feel the most comfortable. And so unlike, a level 1 trauma center or a designated stroke center, the community doesn't necessarily know that if I have traveled and I have suspicion that I don't feel well and there's suspicion that I was exposed to something, they're not going to be able to go online and look for, here's the top 15 hospitals, here's the next 75. They're going to go to their local community emergency department. And so that's where we come back to ready or not, patients will come. And our mindset is, how do we then get ready? And one of the ways that I think we can help prioritize some of these activities is through our healthcare coalitions. And so if your hospital is a member of a healthcare coalition, or you have a local coalition, the hospital preparedness program funding that is also distributed through ASPR now has requirements for a development of certain annexes, including a special pathogen annex. And so one of the best ways that we have identified is, how do you develop an exercise that can meet multiple groups' initiatives, right? So if you need to do something for CMS and you need to do something with your infection control department, the Healthcare Coalition is working on their special pathogen annex. EMS needs to do a transport exercise. Can we craft a scenario that meets multiple objectives for multiple organizations that moves us forward, so we're not doing 15 exercises a year? Nobody has the time or resources to support that right now. I think even with some of the top threats of severe weather, armed intruders, cybersecurity, we have to figure out a way to put this higher in the list of threats, because as you noted, one individual results in potentially 170 exposed individuals with a high virulency pathogen that can have devastating effects on a community and shut down local hospitals that maybe only have 25 beds. And so how do we prevent that from happening is really, our priority is protecting the healthcare workforce to be able to provide safe and effective care to improve patient outcomes. One of the metrics of success for the National Special Pathogen System is 0 preventable deaths after a special pathogen infection and 0 community transmission. And so in order to do that, we have to start getting people interested, excited about the resources that are available, and to your point, moving it up on the priority list.
To your point, I did exactly what you talked about back in 2015. So we had, I drafted a scenario for our facility where we are a level 2 under the current National Special Pathogen System, and we have 2 level 3s in our capital city. We drafted this scenario that they had a patient brought to them, and they're basically a testing center, if you will. So this patient could be brought there, be tested for a special pathogen, and be cared for in a safer environment, and then moved on if they would test positive. We came up with a scenario where that occurred, and then for some reason, Nebraska, our respect, our level 1, was unable to care for this patient. So the scenario I wrote was that they had to transport, and this got our EMS crews that we train in our state involved. They had to transport the patient the 2-hour trip to us as a level 2. But there was a derecho moving through the state at the time.
Yeah.
And so, so that's how I got the rest of my command staff going and involved, that we had a derecho coming, and then, did the whole damage thing and power outages, and, we had some trauma cases come in. So it was a very complex kind of exercise. But then we also incorporated a full-scale admission of this patient to our special pathogens unit in the process. So it was a lot of birds being killed with one stone. Basically, that can be done. And to your point, we don't have the time to do all these individual scenarios. You got to combine them, and that can be done.
You can. And, we just had, I think, the privilege of participating in one of the largest, if not the largest, exercises designed and executed by the Health and Human Services ASPR. There was over 50 different organizations involved, and it really focused on how do we improve domestic transport of individuals suspected or confirmed to have a high consequence infectious disease. And so NETEC served as the evaluation entity to provide expert evaluators for all of the sites that were participating. And the regional treatment centers on the eastern side of the United States, so in regions 2, 3, and 4, the scenario indicated that there was a group of individuals who needed to be transported from Oconus or outside the continental U.S. So we practiced the air transportation of HCID patients and distribution across the regional treatment center network. And through that exercise, we also identified an opportunity to engage the National Quarantine Unit, anticipating that while we would like to say there will be 0 exposures, if we don't identify a pathogen situation early, there is potential for exposures. And then how do we support those healthcare workers, family members, community individuals? And so we were able to leverage the National Quarantine Unit to talk about quarantine services for exposed individuals, and then subsequent movement of those individuals into isolation. So we effectively activated the entire regional treatment center network in coordination with our federal partners to start to look at how do we distribute patients, what's the ethical framework for distribution, what's the impact of ground versus air based on time and distance. And so that just concluded on the 27th of June. So we haven't even finished hot washing that exercise yet. So I don't have any high level lessons learned. But I just want to impress upon folks that we have multiple small exercises leading up to large national initiatives. And all of these are a critical component of putting together a functioning system that will continue to be sustained. We've started and stopped special pathogen systems over the last 10 years, depending upon administration and priorities and federal funding streams. And so we're really now looking at how can we sustain a system independent of the federal funding structure and looking at different strategies to put together creative solutions for relationship building support. You had noted that our team was able to come over to Iowa to support and really stand shoulder to shoulder just to provide whatever might be needed to the team at UIHC. That's also the model that we're looking at for all of the regional. So how do we provide experts to the places where patients show up? It is unlikely that patients will always present to 15 hospitals out of the thousands in the United States. And so how do we create a mechanism to provide expertise either virtually or on site to ensure that we're supporting those frontline clinicians and then rapidly moving people to the right patient, right bed at the right time?
Absolutely. And I think just one quick kind of expanded concept. Could you go a little more in detail on the National Quarantine Unit? I know you are the leadership in that. There's a lot of people in the country that don't know that exists. Could you give us a little bit more detail and background on the NQU?
Yeah, thanks. So the National Quarantine Unit is a 20-bed facility. It is the only federally funded, localized entity to provide quarantine services. And so it is not a federalized building, but it is a federally funded program. And so it is co-located with our biocontainment unit on the University of Nebraska Medical Center campus. And the work for that started back in 2016. So from 2016 through 2020, we constructed the floor. It has all the engineering controls that you would anticipate having in a biocontainment unit, including negative air pressure, sealed non-porous flooring and walls, easily wipeable surfaces. Each of the rooms are 300 square feet at a minimum with an ensuite. And they're designed to be able to house an individual for up to 30 days, which would include the majority of the incubation periods for known high consequence infectious pathogens. The intent of the quarantine unit is really to provide one centralized location where you can have expert observation, but it is not a clinical care facility. And so they're not licensed beds from the hospital. It's a separate entity, but we staff it with the same individuals that would provide care in the biocontainment unit. So infectious disease physicians, med surg and critical care nurses, and then we have emergency medicine physicians who consult for day-to-day management if anything arises. The unique part about the National Quarantine Unit is that while it's federally funded through ASPR, we also worked really closely with the Centers for Disease Control, Department of State, so that really it could be used for community citizens, governmental workers, or deployed healthcare workers. We had anticipated that this would be used for able-bodied individuals who are deploying upon federal missions. The reality was that 6 months after we said, yep, the building is ready, our staff is ready, we were asked to activate in response to SARS-CoV-2. And so we received individuals repatriated off of the Diamond Princess cruise ship. And so we quickly had to reevaluate our entire infection prevention and control posture because part of that cohort were already confirmed to be positive. And so we were not providing quarantine, we were providing isolation. And so isolation, providing a safe space for people who are infected so that we don't continue to spread pathogen to others versus quarantine. You've been exposed and we want to make sure that we provide a space where we can safely monitor and observe. And so our experience with that was very different than how we had initially planned to use that space. And then we've had subsequent activations for monitoring individuals who've been exposed, but no other isolation activations. Yeah, so we have 20 rooms. that are designed to provide care for up to 30 days for individuals exposed to a high consequence pathogen.
That's a big part of this dilemma in dealing with high consequence or suspected high consequence pathogens, right? Is the isolation, air handling, and the personal protective equipment that just,
Mhm.
I think it boggles a lot of frontline staff about what might be needed or what is needed at a larger level. But it's a reminder to be observant and not, I guess, evolve into 170 or
Right.
more exposed people, right, Mike?
Well, the point is, and you make a good point, Chris. We did have 170 exposures, and I can't remember the total number that were considered to be high level, high risk, right? I was one of them, but I had PPE on. And so did a lot of the healthcare workers that were exposed along the line before the patient and when the patient arrived with us. But what we identified was that most of the time, the healthcare providers were at least following universal precautions, right?
Mhm.
They may not have had the full gambit of PPE that you would prefer to see in a case like this, but they at least had gloves on. Some of them had masks on. Maybe they didn't have eye protection. Maybe they didn't have N95s. Maybe they didn't have this, didn't have that. So as we look back at those cases, I know our public health people have been looking at it pretty intently, and our infection control folks as well. It's like, well, were we just lucky that nobody else seroconverted, or did the fact that most everybody did universal precautions at minimum, was that
Mhm.
a factor? And the other things we had to look at too is that this patient, even though they were symptomatic upon entry into the system in a quick care, if you will, and moved up through a level 4, then to a level 2 facility, um, their viremia, the amount of virus, the viral load, if you will, that was in the patient's body, maybe early on, even with the family members that the patient had, none of them seroconverted, and they sure weren't wearing any PPE when they were around them early on. Earlier in the course of the patient's condition, the viral load, at least in this particular virus, may not have been that significant to be able to be communicated to another person. Now, had this been to a different virus, and Angie, I don't know what your thoughts are. Had this been something else, I mean, maybe we were lucky it was Lassa, because Lassa's got a large range of how it presents and the outcomes. Only 5%, right, end up needing hospitalization, and I think only 1% really face fatality. So, but if it had been Ebola or Marburg or something like
Mhm.
that, we could have had a much different outcome, don't you think?
I do, and I think that the reinforcement of using universal precautions and really thinking about how do we protect ourselves from transmissible pathogens. So even if we don't know what it is, if we're doing gown, gloves, and a face mask, that's covering 95% of what you need to cover. And if you add on eyewear, all your mucous membranes are covered. And so I do think that it can feel very overwhelming for frontline staff, particularly in rural areas. And you're seeing, B-roll footage of individuals in a full coverall with a powered air purifying respirator, a PAPR, a full hood, outside boots, multiple gloves. That feels very daunting. What I would remind us is that wearing a fluid resistant gown with one pair of gloves and a face mask and a face shield, you are protected. People that are presenting in the case study that you're representing, Mike, is if you have an individual with early symptoms who's considered a dry patient, so they're not vomiting, they're not having diarrhea, they're not having a lot of coughing or other body fluids being expelled, that level of PPE is protective. And so if we can use that mindset of I know how to protect myself in standard precautions, the next step is put them in a private room with a door that closes with access to a private bathroom or a commode that you can safely dispose of human waste. If we can get those things hardwired, that's 95% of what we need
Mm-hmm.
to safely isolate an individual. And so I think, in some ways, yes, we were fortunate that the pathogen that presented was something that has, a longer trajectory of like having high viral loads. The infectious dose is a little bit higher. You need more virion to infect somebody. And I think it's a good way for us to look at it and say, how do we do better the next time? I think the only thing that I would add is we also, I think, took a very conservative approach to categorizing individuals as exposed versus participatory. And so I know even our team members who were completely compliant with all protocols and all PPE were put into the high risk category and did twice daily monitoring with public health, checking temperatures and reporting symptoms or absence of symptoms because nobody had any symptoms. But even just being told, you've interacted with an individual who was confirmed to have this type of a pathogen, we're going to place you in the high risk category because you were in the hot zone, you were providing care. That does something to your mental state, right?
Oh
It really starts to make you think, I feel a little bit nauseous. Am I tired,
yeah.
or is this a symptom?
Yeah.
I feel fatigued. Am I not sleeping well, or is this a symptom? And so I think shifting our healthcare workers' mentality to have confidence in the practices that they're the processes that they're practicing, and knowing that just because you're put into a high risk category doesn't mean that you have a high risk of getting ill. It just means that we want to monitor to make sure that everything was done correctly. As you said, I've been in this role for quite a few years, and even for me, I had to reach out to my team and say, here's what I'm feeling today. We had a trained observer. We knew that there were no breaches, there were no exposures, there were no lapses in protocol. But you have to have that peer support saying, I feel anxious and I don't know why, and just reinforcing that that's okay. Healthcare has changed, particularly since COVID, and so I think that we have a much higher risk of burnout, a much higher level of stress. And so, how do we provide support for healthcare workers who are responding to these scenarios and recognizing that it's okay to not be okay sometimes?
Excellent point. Excellent point. Hey, what keeps you up at night? What outbreaks, what evolutions, diseases?
Yeah. So I think the thing that keeps me up, there's two. One is, a intentionally bioengineered, genomically altered pathogen that's intentionally released. So I think that's one that we can't predict. So, pathogen X that is intentionally engineered to be as destructive as possible. And then the other naturally occurring is, an airborne pathogen with high virulence and high mortality. So if we saw something similar to a MERS-CoV with, 30 to 50% mortality rate that was upwards of 70 to 80%, it's airborne. We don't have medical countermeasures. We don't have prophylaxis. We don't have post-exposure prophylaxis. And then we start to see this wide dissemination. The number of negative pressure rooms that are available across the United States, even post-COVID, is not sufficient for us to quickly and safely isolate a large number of individuals with a very virulent airborne pathogen. So that's what keeps me up at night. I mean, viral hemorrhagic fevers, I think, are concerning just because of how the high lethality, but they're droplet contact. And so that the airborne pathogens is really what keeps me up, like high numbers of patients that overwhelm our systems. And then we have healthcare workforce that's impacted. So, early COVID, but with a much higher mortality rate is what keeps me up. What about you two? You guys have worked in emergency response for, and in healthcare adjacent roles for many years. What are the things that keep you up at night?
Really, any phone call to Mike, he starts scaring me. Mike starts telling stories about tick-borne,
Oh,
foreign illness sort of things, and it's like, yeah. I mean, there is this balance, right, of horrible, high consequence. I mean, we still have issues of the Black Plague, the bubonic
right.
plague in our country that people don't know about. It's just getting educated. I think I think the greatest illness we have is ignorance and lack of commitment to a basic level of education and preparedness.
I have to agree with you. I think I'll add to that I think, Angie brought up a really good point about complacency after COVID. I think, unfortunately, the way COVID was framed in some circles, that, people just go, we dealt with COVID, it was all this Trump, this cranked up thing that was just, wasn't any big deal, although we were the ones hauling the body bags out of our hospitals. And so we know how bad it was. But, the fact that I think we need to be more concentrated and more collaborative on our vigilance and on knowing what's out there and the situation that we're in. If somebody learns something about something over here, this part of the world, or this kind of case in this part of the country, we as a group, as a collaborative team, need to talk to each other and say, hey, I heard about this over in this part of the country. You guys might want to think about this. Look at H5N1, for example. That's getting a lot of attention. I know our researchers here are working on a vaccine. And so, I mean, what's out there next? Angie mentions this virulent airborne type of thing. Who knows what could pop up? I just think something is fomenting out there somewhere. And it's not a matter of if, it's a matter of when. And we need to be, and my fear is that we may not know it, that it's out there until we've it's gotten a significant foothold into our population. That's my concern.
I think I agree with both of you. And, one of the upcoming events that I think will put a fine point on why we need to start to focus on preparedness for potential for widespread infectious diseases, the upcoming World Cup, right? There's going to be multiple sites, multiple games happening in multiple places across the country simultaneously with people traveling. And while we have, a lot of international travel, it's usually point to point. And so now we have this opportunity for many, many people from many, many places going to a lot of different places within the United States and mixing in different combinations. And so I know a lot of work has been done at the local level, at the state level, and at the national level to start to really look at how do we prepare for all of the hazards that could potentially happen in these large events. And I think infectious disease is just one of many, but it's the one that my team focuses on. So it's the one that comes to top of mind for me. And when you think about, tens of thousands of people in a stadium, and you think about an airborne pathogen that's been imported from, a traveler who maybe didn't realize that they were ill and they're shedding asymptomatically, that's when you have those potential super spreader events. And I think we have the luxury now of having a runway where we can start to think about, if I am a community that's hosting a game, or I'm in an area around a community that's hosting a game, where are people going to present for care? And how do I start to get my staff ready to think about what should we be looking for?
Excellent point.
That's perfect.
Yeah, because point. I mean, you nailed it on the head. You're jumping on an airplane. You're coming from one part of the world to another part of the world, our part of the world. And that person who got on that aircraft may not know they're sick. Our case was not. He was asymptomatic until about 8 days after it landed. And so these things can jump on an aircraft and be here. And it isn't necessarily going to be somebody from a foreign country. The case that we had was an American citizen who came back from a foreign country, but was an American citizen. So, you can't just go by, oh, well, they're a native of another country. It's going to be something like that. No, it's not. It can be anything.
And while we focus on domestic preparedness, I think the reality is people could come here and be exposed to something that is not endemic in their own area. Like you mentioned, H5N1, or, there are other things circulating, whether it's mosquito-borne or tick-borne or, vector-borne illnesses that may translocate back to where that individual is returning. And so while, we focus on how do we protect our borders here, we also have to think about the global impact of people going multiple places. And so we did do a national, the NSPS, National Special Pathogen System exercise in collaboration with ASPR, really looking at how do we prepare within the sites, within the cities where regional treatment centers are co-located, where there will be a World Cup game. So we did a large national tabletop exercise a few months ago, really starting to look at how could we mobilize the system should an event occur. Where are the gaps? Where are the vulnerabilities? And how do we strengthen those in advance? Because once the games are starting, it's too late, right? We have to have these things ready before we get started.
Absolutely.
So, right.
So to review, Angie, let's kind of review the system once more. So thinking in levels like trauma, like stroke, a level 1 special pathogens treatment center is what exactly? What are their capabilities?
So a level 1 treatment center is really the resource hub. So they are designed to be able to provide specialized care for patients of any age with any type of high consequence infectious disease. So from neonate to geriatric, labor and delivery to pediatrics. And this would be for the duration of illness up to and including critical care interventions. The paradigm of care delivery for special pathogen patients has dramatically shifted from 2015. Previously, the mindset was that we will provide supportive measures, we'll do, everything that we can within a set amount of parameters. And now we're really looking at how does aggressive IV fluid resuscitation improve outcomes? What does intensive level of care look like for both novel respiratory, but also viral hemorrhagic fevers? Would we do bronchoscopy? Would we do ECMO? Would we do imaging? How do we safely provide continuous renal replacement therapy for an individual who's in multi-system organ failure, while also prioritizing the safety of the clinical team who are providing that care and those interventions? And so those level 1 centers are really leading the way in developing critical care guidelines for high consequence infectious disease cases, providing care for the duration of illness for at least 2 patients confirmed to have a viral hemorrhagic fever and at least 10 individuals with a novel respiratory pathogen. In addition, level 1s are also expected to be the resource hub for their communities. So we're developing and delivering education and training, consultative support, working on the state and regional plans, coordinating across the different states in the region. So that's really the level 1, very equivalent to what a level 1 trauma center is expected to do. The level 2 has that same clinical responsibility to provide care for a duration of illness up to and including specialized critical care intervention. But there are some caveats in that they're not required to provide pediatric care. If they're an adult peds joint hospital, they could say our best capabilities to do adult only care, or our best capabilities to provide care for both adult and pediatrics. For level 2, you could also be a standalone pediatric hospital. So we know that pediatric beds in general across the United States are always at a premium. Critical care staffing for pediatrics, particularly burn, is very challenging. And so when you add on specialty care for high consequence infectious disease, it has that same connotation of challenge. And so we were really hoping to stand up more pediatric centric children's hospitals within the level 2 structure. They're also not required to provide education, training, and outreach, although it is encouraged once those programs are established to partner with the regional. We would never say, you can't do that, we're doing that as a level 1. But we also recognize that there's less funding, there's less staffing. And so we want to make sure we're prioritizing that clinical care capability for the level 2.
Mm-hmm.
Level 3 is what we would call an assessment hospital. And really, we're asking that they would be prepared to provide safe isolation capacity for individuals for 12 to 36 hours to be able to safely isolate, identify their closest laboratory reference network partner, or an LRN, LRNB, their state public health testing lab, where they could safely send a specimen to either rule in or rule out the pathogen of concern. So up to 4, a cluster of 4, which is, maybe a family that would present for care. How do we safely isolate those individuals, get them tested, and then have a plan to coordinate transportation to that higher level of care? So not expected to provide definitive care for duration of illness. And then level 4 is really anywhere else that somebody could present for healthcare. And so really asking them to be able to quickly identify, isolate, and inform, and be able to coordinate movement to either a level 3 or a level 2, whichever is geographically closer. Not ruling out a level 1, but it's likely that they will be closer to a different level of facility. And really the linchpin in the system that we don't have time to get into in depth today, though, is our emergency medical services.
Bingo.
It's fantastic to have a health system or a special pathogen system. If we can't move patients across the system cannot function. And so identifying the EMS partners that are willing, able, and prepared to provide that transportation. There are large swaths of the country where there are more cows than people. And that's not just in Nebraska, it's in a lot of other states. And so we have to have EMS support to move individuals to those higher levels of care.
Yeah, you're talking to 2 old EMSers. Us, the
Right.
2 of us are both.
Yes.
And so we know that is a major issue. And, let's face it, it's tough to do that kind of work. Even, a medic is willing to work in the world of special pathogens and learn the transport techniques and undergo the training. but the PPE that's required and the environment they work in, it's a very short duration that they can physically tolerate being involved in a transport. And so, that's where I'm so glad you guys had that exercise last week for air assets and things like that. As more and more air assets are accumulated and created, I think that's going to be a major step forward for the system.
So for folks who are listening to this and you're interested in the transportation dynamics, the Portable Biocontainment Unit, or the PBCU, is the newest designed air transportation asset that was designed and funded through ASPR. And so this is the transportation asset that we tested in the exercise this last week, and really looking at how do we provide a better service to move people more safely and protect our healthcare workforce, particularly the EMS individuals and care providers, so that we can put the individual into a pressurized system that provides negative pressure, comfortable accommodations that could be moved from air to ground with minimal impact to the team and to the patient being moved. And so a lot will come out of this exercise, I think, in the next few months, but really a step forward in having a domestic asset that could be used by the regionals, by the federal government, by our local partners to safely transport folks from point A to point B.
So, Angie, that module that was put on board a 747 flip-up nose cargo aircraft, right? Can it fit in a C-130?
It could, yes. It could fit in it's an L100, a C-130, or a 747. And so it's about, don't quote me on this, but around 54 feet long. And so it's designed to be on a semi-trailer and into a cargo aircraft.
Okay, that's what I thought.
Mm-hmm.
I'm seeing the future in drones. No, I have no idea. Seems like in warfare, it's that. Maybe we can find that in healthcare. We'll see. Some talent.
Great idea.
Hey, Mike, I just want to be conscientious about everybody's time.
Yeah.
Anything else that you wanted to make sure that we draw out of Angie in terms
I think
of
Angie she's just such an incredible resource, man. This is a rare individual over here that we've got the privilege of speaking with today. Angie, I'm going to turn it back to you. You've provided a lot of information for our colleagues in healthcare preparedness. I'm going to give you the summary here. What's out there? What else do you want us to know? What has to get out to our colleagues around the country?
Yeah, I think for closing in, some summary key points would be: number one, know who your resources are. So if you are not familiar with your regional treatment center or NETEC, I would really encourage you to go to our website. It's www.netec.org. There's a plethora of information out there across all of our programs, the NSPS, the regional treatment centers. And then I would say reach out individually. So info@netec.org, or you can use our Ask an Expert button on our page. There are no stupid questions. We are here to help. I would also re-emphasize that all of our services are free of charge because we are federally funded. And so it's a question we get a lot: is how much is this going to cost me? Nothing, except your time, your energy, and your commitment. And so I would just say, if you have questions around protocols, staffing, PPE, what is a special pathogen? How do I know if it's a special pathogen? That's what we're here for. And the more that we can engage, the more successful that we feel we're being. And so that would be probably the two things. And then I think lastly is just to quote one of my former colleagues is, it is true, ready or not, patients are coming. So let's get as ready as we can.
Awesome. Hey, then to kind of tailor the tail end of this, it sounded like EMS was a specific audience that we want to really draw in.
Yes.
Yeah, EMS and I don't know, school nurses. Are there anybody else that you're really wanting to make sure that we bring the message to?
Yes. So I think local public health departments, understanding that we are a resource, we've partnered with multiple state health departments so that we could go out and partner with them. We provide an assessment to the organization, and then we partner back with the state health department, who either doesn't have the resources to go on site, but they want to be able to support some of this programming, to partnering with state and local public health departments. And then around EMS, so NETEC does have a biosafety transport consortium. It's run through a group of EMS professionals who have provided care for real world events for patients either suspected or confirmed to have a special pathogen. So that's a large consortium really focused on improving the safety for EMS professionals. We also have an EMS work group, which is led by Dr. Alex Isaachoff out of Grady
Great guy.
Um, Great guy, and he's done a lot of real world transfers as well as exercises. And so we have EMS assessment tools. We have an EMS biosafety transport operators course. We have many webinars focused specifically on EMS. We have a rapid readiness assessment tool designed for an EMS agency who may be called upon to do transport, and how do we make sure that you're as ready as possible. So we could do a whole segment on NETEC EMS readiness, and would love to put in an EMS person, because while I can talk about all the great things we have, I'm not an EMS professional, and so I would never pretend to be one. But we do have an entire division of NETEC that's focused on EMS preparedness, and so I would really encourage EMS folks to seek us out. So infection preventionists, nurses, physicians, emergency medical services, public health, and then laboratorians. We have something for all of those types of disciplines.
Wow.
And then anyone who's just interested in special pathogens, I think we're the place to come.
Absolutely. One-stop
Except for
shop.
bad people. Not for bad people.
No.
No bad guys, good
No
guys.
bad guys. No state actors.
That's awesome. Awesome. All right. Well, Mike, you got some last minute kind of housekeeping details about this?
Absolutely. And we want to take another minute to thank Angie for giving her time and go through that extra effort to get on with us today. And, truly one of the most important guests we've had in our, a little over a year and a half of this podcast. Really one of the most important people we've talked to, because, let's face it, it's not a matter of if, it's a matter of when. And so the buck stops here and with this organization. So thanks to Angie for spending her time with us this morning. And to all you out there, we're so glad you stopped by. I hope you come back. If you have any questions or want to get a hold of us about this particular topic, if we can help you and direct you to these resources, let us know. We are reachable at readiness.rewired@gmail.com. We want to hear from you too. Do you like our content? Do you think we suck? Let us know. We want some input, and we sure hope you come back again and join us as we try to improve the emergency preparedness of the healthcare infrastructure in this wonderful country. Come by again.
Hey, and Mike, one more thing is the description of this on YouTube, where we house our collection. We'll have some links and some opportunities to connect with NETEC as well.
Absolutely. We'll put some hot links in there so you can get right to this group.